I recalled what I wanted to say about testing hearing. Why do we as PTs care whether our patients have functional hearing or not, other than, gosh, we'd like them to hear what we're saying to them? The important thing is that, as you know, cranial nerve 8 is not only the acoustic nerve, but is the vestibular nerve. So if you have someone with acoustic issues, they may very well be a fall risk as well, and that's the clinical pearl. Now, thinking about conduction of sound, recall that sound can be conducted through air or through other media. In the human body, sound is conducted through bone. So we need to figure out a way to test whether a patient's hearing loss is a sensory nerve loss or whether they have lost bone conduction. The way we do that is through the Weber test. So you use a 512 Hertz tuning fork, and you strike the tuning fork, and I hear it. You strike the tuning fork, and you place it in the center of the patient's head. They should tell you that if it's placed in the center, that they hear the sound equally in both parts, in both ears.
Yes.
Fabulous. If a patient has a bone conduction loss, they're going to tell you that they hear it more in one ear than the other. Otherwise, they should hear it equally. Now let's try and distinguish between air conduction and bone conduction. Air conduction lasts longer than bone conduction. You can hear something longer in the air than you can if it's conducted through the bone. So you take that 512 Hertz tuning fork, you strike it, and you place it on the patient's mastoid process, just behind the ear. You can hear it, right?
Yes.
Tell me when it stops.
It has stopped. And I hear it again.
Tell me when that stops.
It has stopped.
Catherine has really good hearing. Don't sit near her in class. She'll hear everything you say. So, and that's actually a perfect response. So the patient with a bone conduction loss obviously is not going to hear anything. They're going to tell you, I can't hear it. Put it to the air, see if they can hear that. Someone who doesn't have as good a sensory response, you're going to hear it through the bone. I can hear it. And then when it's gone, you're going to put it to the ear. Well, I don't hear it anymore. I still don't hear it. So you're going to be able to distinguish between air and bone conduction. There are some interpretive results that we will talk about in lab, air conduction versus bone conduction. The most confusing thing to me when you're looking at the Rinne test is that we talk about a positive test being a test that gives you a finding of pathology. Somebody with a positive Lockman's has ligamentous instability. It's reversed in the Rinne. Somebody with a positive Rinne is normal. So then you have to turn your head all the way around and it gets confusing. So I do have a chart that I will share with you in lab regarding that. Just a little episode of things to come. The final thing for the ear is the use of the otoscope. And the otoscope is easy enough, and honestly, a lot of your clinics should have them, that I want you to go ahead and get familiar with using them. The otoscope looks almost like the fundoscope, except for the top part. There's a lot less moving pieces, so it's easier to manage. You figure out how to turn it on. This, again, is not on because we're not going to really do it, but you figure out how to turn it on, and you look into it, and that's about it. So, again, thinking about the anatomy of the adult's ear canal, the best way to visualize in the canal is pulling up and back. This is not going to be comfortable for someone with an infection. So if they tell you it hurts, please listen to them. If they're okay with it, just get as much tension as you can to open the canal as you can, as wide as you can, and then put the otoscope in and use your distance as your focal point in order to focus. So you're going to look in, and what you'll see is a buff color or light tan color sort of a thin sheet, and that's going to be the tympanic membrane. You're actually going to see someone's eardrum. Now, what appears to be behind that is almost like a shadow with a white outline, sort of a semicircle with a hook on it, and that is the light reflex striking the malleus that's behind the eardrum. The important thing that you're trying to do, first of all, if you're concerned about hearing in your client, is to see if they have so much wax or cerumen in their ears that it's absolutely just occluding the canal, and maybe that's why they can't hear you. That would be a very easy fix. Send them to their physician to have their ears washed out. Failing that, what else you're trying to determine is, do they have any kind of inflammation or infection, and is it in front of or behind the eardrum? If it's in front of the eardrum, it's otitis externa, in the external ear canal. If it's behind the eardrum, you're going to see redness and almost a palpable pushing out, visible pushing out of the eardrum. That tells you that it's otitis media, and that gets to be a big problem. That can affect other structures, of course, not only the middle ear, but think about your vestibular system, your semicircular canals, all of that good stuff. That's something that I would recommend calling the patient's physician, getting him into the urgent care clinic that day or the very next day, at the minimum. Now let's move on to the nose. The nice thing about the nose is that we're going to use this piece of equipment again. Your otoscope can be used as a nasal viewer as well. Of course, this is why we have our alcohol wipes handy, because you don't want to stick it in somebody's nose and then go on to some other person's part of the anatomy. As with everything else in this part of the body, we're going to observe first. Then we're going to palpate. Then we'll actually get to use some percussion and transillumination before we grab the otoscope again and look further. So when you're inspecting the nose, I'm going to sound like a broken record, I'm looking for symmetry. I want both sides of the nose to look the same. I'd like the nose to be in the midline. I'd like the contour to show that hopefully it's never been broken or mangled. I'm looking for any kind of drainage, polyps, nodules, and you may have what they call a nasal speculum, which will widen the nasal passage that you can use with the otoscope. I do not have one of those, but I'll just demonstrate using the otoscope as itself. Again, the nose and the sinuses, when you start palpation, go light. You're looking for any tenderness, pliability, and the general texture of the skin. I tend to do this bilaterally just to reassure the patient that I'm not going to press directly on their nose. I tend to start with the sinuses, and I'm just gently palpating. No tenderness?
No tenderness.
Great. And then I'm going to move more to the bridge of the nose, and then to the external nares themselves. Once I've palpated, I can move to percussion. Thinking about where the sinuses are, the frontal and the maxillary sinuses, I'm going to percuss directly over them. If there's any kind of swelling or infection or fullness, the patient should notice some discomfort. Again, be nice to your patient, start lighter, and then go deeper if you have to. So, very gentle percussion. Any difficulty with that, Catherine?
No.
Now, you may see, this is totally normal, Chvostek sign or Trousseau sign, where you get that reflex if you hit part of the face. So if the patient starts blinking as you're doing that, that is totally normal response. Doesn't mean they have some kind of neurologic deficit, especially if I start going over the maxillary sinuses. Anything with that?
No.
Okay. So that's the percussion of the sinuses. The final thing we're going to do is transillumination. You'll get to practice this with the lights off. Again, for demonstration, I'm going to do it with the lights on, but I am going to use the pen light so that you might be able to see what's going on. I'd like us to zoom in for a closer look at this point. What you're going to do is take the pen light and you're going to use it as if you're illuminating a cavern. I'm going to put it right at the ceiling of the orbital fossa and shine it. Ooh, and Catherine has light enough skin. I can see just a very faint pink glow. Now again, it's going to be hard to do this with the lights on, but I know what I'm looking for, so I can tell you. It's also important that when you're using the pen light, you're not directing up because you don't want to get pink right at the eyebrow because that's the light coming through the skin. What you want is almost a 45-degree angle, thinking about where the sinus is and getting a faint pink glow above the eyebrow. Was that uncomfortable as I was pressing?
No.
Many people, thank you, again, didn't pay her for that. Many people don't press hard enough because they're afraid of hurting their clients, but you're going through bone. Now it's thin bone, but you still want the light to be able to show through. The illumination of the maxillary sinuses is quite cool. I'm going to check it first before I have you zoom in. You're going to put it at the floor of the orbital fossa and then open your mouth for me. No, it's not going to show. No, not going to show on Catherine. What you would see is if the patient, if you can get it where it needs to be, and if the patient has, you don't have any sinus issues today, do you?
I do not.
Okay, good. If the patient has thin enough bony structure, you should actually see light shining through on the roof of their mouth, just a little light red glow on the roof of their mouth, their hard palate. Okay. Speaking of the mouth, now we move to the mouth. And guess what we do first? We inspect it. We look at it. The mouth is served by cranial nerve 7, 9, 10. So this is where I would pick up the cranial nerve 7, the facial muscles, check, as well as 9, 10, looking for the hypoglossal reflex, looking to see where the uvula falls, and then using the otoscopes to actually look in the mouth with the tongue depressor, if at all possible. So when you're inspecting the mouth again, got my gloves on for her safety, we're going to look, inspecting first the outer structures. Are the lips symmetrical? Is the mouth in the center? And then before I move on to actually inspecting the rest of the mouth, this is where I'd put in my facial nerve. Now remember, I told you that I was going to add in the closing of the eyelid, which is a different cranial nerve, but it falls better here. So, keeping your eyes straight forward, Catherine, can you open your eyes as wide as you can? Close them as tight as you can. Good job. Give me a worried expression with your brow. Look worried. There you go. Raise your eyebrows. Now frown. I know you don't do that very well. You usually smile. Good girl. Good, good. Can you wrinkle your nose like you're smelling something funny? Good. Can you draw back your teeth? Good. Purse your lips like you're drinking from a straw, and then stick out your mouth, or your lower lip like you're pouting. Perfect. That's a pretty gross test of cranial nerve 7, but it'll get you there. And then I also, before I forget, when I start palpating the mouth and structures, this is where I'll also slip in the sensory portion for cranial nerve 5, the trigeminal nerve. But we're back on inspection of the mouth, so this is where I'm actually going to take my gloved hand, and I'm going to go ahead, just relax. I'm going to open your mouth a little, and I'm looking not only at her gums, but her general dentition. You can look beneath the sublingual, beneath the tongue, the sublingual area. You can stick out your tongue. And while we're here, side to side, remember, thank you ma'am, that the tongue, cranial nerve 12, is a protrusor muscle, so it will deviate to the side of weakness. This is where I would pull out either my otoscope or my pen light, and I will take a tongue depressor. Everybody hates this part. Open your mouth. Now, there's more than one way to check for people's uvula and their tonsils. Most people, they say, stick out your tongue and say, ah. The difficulty with that is that then it's very hard to move the tongue around with your tongue depressor. So what I say is, open your mouth just nice and easy, and just let your tongue relax. Just, yeah, there you go. And then it's easier to press down. Do not press so far back that you gag your patient. That's another good way to check cranial nerve 9, but not the way we want to do it. So just open your mouth a little bit more, yeah, and just relax. And then you can shine your light right in there and look for the uvula. And if you're lucky enough, the tonsils. Sometimes what I'll tell my patients is, think about dropping the back of your jaw so that they're going, ah, as opposed to, ah. And then you'll see further back in the throat. So again, we've tested cranial nerve 7, the motor function. This is where I would add in cranial nerve 5, the trigeminal, just checking to see if they can feel light touch, all 3 branches of the trigeminal. Looking for the uvula gives you the glossopharyngeal. Cranial nerve 10 would be the vagus. Most of the patients I see, I can tell if they have vagal nerve issues because they're usually feeling nauseous or dizzy, feeling like they need to vomit. Let's finally move on to the neck. The important thing about the neck is the lymph nodes. When we think about, as we mentioned in the very first year, when we think about a particular examination technique that is the best for discriminating infection from neoplasm, we think about palpation of the lymph nodes, because tender and enlarged lymph nodes usually means infection. Non-tender and enlarged lymph nodes usually means neoplasm. So when we're palpating the lymph nodes, we're going to remember our anatomy, and we're looking for the lymph nodes where they lie. Now, there are a few other things in the neck that we need to talk about. We need to find the thyroid gland, we need to think about the vascular structure, and we need to think about the trachea. Let's start with the lymph nodes and then move on to those other structures. When you think about the lymph nodes, think about them almost as a chain. Now, there are some that are separate from others, but it's easier for me if I think about going in a chain. I'm going to start with the preauricular, and obviously I would do this bilaterally. I would start with the preauricular, move down to the tonsillar, move along the submandibular to the submental, come back to the anterior cervical, which essentially is directly in front of the sternocleidomastoid, then the posterior cervical, which lies more or less in the hollow behind the sternocleidomastoid, but along the paravertebral muscle line, and then finally the supraclavicular, and that's directly on top of the clavicle. So they're named for where they're located. Now, some points of palpation. Notice that I'm behind the patient. For me, that's easier because that's how my hands fall. If I'm in front of the patient, I feel like I'm pushing. Whereas here, if I'm behind, I feel like it's a much gentler touch. Remember that lymph nodes are, at least in this area, not deep. So I don't have to be grinding down to bone. I'm really staying as superficial as I can, and I'm just trying to feel if there's any kind of thickening or enlarging of the nodes anywhere along that pathway. And I'm not finding any, which is very good news for Catherine. You're not feeling ill, right?
I am not.
Yay! A good lab assistant. Now, some primary care practitioners will tell you that there's a difference in the potential disease that's indicated, especially the infectious disease that's indicated, if the anterior versus the posterior lymph nodes are enlarged. I have not been able to verify that, looking through the literary journals, so we're not going to cover that, but you may hear that out in the clinic. And if that's so, that's great. My deal is, as a physical therapist, if I find any kind of lymph node enlargement, I'm going to let the physician know. All right, let's talk about those rest of the structures, the thyroid, the trachea, the carotid artery, the jugular vein, so the vasculature of the neck. Again, I feel like the posterior approach is better. However, if you're going to do the anterior approach, I don't want to occlude your vision, but you're going to be directly in front of the patient, and your hands are going to be, for the most part, pointed upward. Again, to reassure the patient, light touch before you go deep. I'm a fan of the posterior approach, so that's what I'm going to demonstrate. Starting with the thyroid. So, when you're thinking about the thyroid, you want to think about symmetry and size. If I'm starting with the anterior approach, I would just find the thyroid and palpate it. With the posterior approach, the easiest way to do it is to go just below the chin. You're going to go about 3 fingers down, essentially where the chin ends and the neck begins, and then you're going to ask the patient to swallow. There you go. And you're going to feel things sort of move, and that's what you want. You want to feel structures moving under your fingers. The best way that I've been able to find the trachea is I find what we call the cricothyroid notch, and that's a sort of a thin area, and that's, by the way, if you were going to do airway, creating an airway in a trauma patient, that's where you get to put your little knife so that you can then put a little tube in to give an artificial airway. That's what that whole little membrane's for, but we're not going to talk about that today. But that's the cricothyroid membrane. So the trachea is what's lying now directly under your fingers in a vertical line. The thyroid gland lies on either side of that, like a butterfly. Now, in the normal population, you may not feel anything at all. If somebody has hypothyroidism, like me, you're definitely not going to feel anything. What you're looking for that is an abnormal, concerning sign is a couple of different things. As they swallow, go ahead and swallow again, Catherine. If you feel that things are sticking, that the larynx isn't able to move up and down, the epiglottis isn't doing its work, that's a bad thing. If, as they're swallowing, you feel a nodule come under your fingertips, that's not a good thing, because that's usually a nodule that's in the thyroid itself. Thyroid nodules can be neoplastic. There are such things as thyroid cancer, but more likely they can be early precursors to a goiter or hyperthyroidism. We already talked about the trachea. We're looking for symmetry. We're making sure that there's no tracheal deviation. You're not going to ever feel the esophagus, but remember that as you're doing all that palpation, there are structures deep to where you're palpating that you shouldn't or can't feel. If anything starts to feel awry, like, well, here's the trachea, but hey, there's this really long, ropey thing that's right beside it, I don't think I should be feeling that. That's something to bring to someone's attention. Because things that are hidden should stay hidden. You shouldn't feel a protuberance of the esophagus, and you certainly shouldn't feel, as we're going to talk about in a little bit, a dilation of the vasculature in the neck. The final thing, while we're still in the midline, is to think about the manubrium, the top portion of the sternum. I always, in addition to palpating the sternal notch, I always just give it a little bit of a percussion because of the thymus gland, all the nice little things that are right behind the manubrium. If there's any kind of irritation or inflammation, that'll bring it out. Also remember that the sternoclavicular joints right here can be aggravated as part of the shoulder complex, and those are worth palpating as well, making sure that those joints are bilateral, symmetrical, not protuberant. In the Army, we used to see sprains of the sternocostal joint, and if it was unilateral, then whenever the patient did anything like a push-up, it would become very, very painful and non-functional. We already talked about the lymph nodes, so the final thing is to talk about the vasculature. So remember, in the neck, anterior portion of the neck, we have the carotid artery and the jugular vein. Remember also that the carotid artery has the baroreceptors which control blood pressure. So I don't want you to be pressing down as hard as you possibly can against that carotid artery trying to take a pulse, because A, you can aggravate the baroreceptors and cause a change in blood pressure, or B, you can occlude the blood flow up to the brain, which, as we all know, is a very, very, very bad thing to do. So, again, my favorite position being posterior, I'm simply going to find the carotid artery in that nice little triangle, and I'm going to feel the pulse. I'm going to take the pulse. I can feel Catherine's right now. If I had a watch on, I would look at that watch and take her pulse if it wasn't already done as part of the vital signs. But one of the things that's nice to be able to do, especially in the vascular population, those with heart disease or diabetes or such things, is you want to just take a look, and what you should not see is you should not see the pulse actually occurring in the carotid artery. That would be a nice, gross, sure sign of hypertension. Similarly, I should not see distension. I shouldn't see the jugular vein. If I see the jugular vein, then there is distension, and that's also something not very good that we want to bring possibly pulmonary hypertension kind of thing. This concludes the head, ear, eyes, nose, throat, and neck, and I appreciate your attention.